Hey gang, this is just going to be a short little presentation on Chapter 22. Chapter 22 deals mainly with cardiovascular conditions, so that special population of patients, or I'm sorry, clients, not patients, who have maybe hypertension, high blood pressure, MI, stroke, cerebrovascular incident, things of that nature. So first of all, looking just at hypertension. Note that hypertension is idiopathic. It's an idiopathic disease, which means the exact cause is unknown. So we don't know exactly what causes it, but we do know that millions of Americans suffer from high blood pressure. So as far as diagnosis, I put must know because you should know what blood pressure numbers should be and where they diagnose hypertension and whatnot. Now, I have this table provided here because this is the one that's in your textbook. But please note that the American Heart Association has come up with some new guidelines as far as diagnosing, blood pressure. But we do know that normal blood pressure is actually supposed to be less than 120 over less than 80. So a systolic blood pressure, which is the top number, diastolic blood pressure, which is the bottom number. So we want to keep it normal. So those numbers should be below 120 and below 80 when you're looking at systolic and diastolic. Now I know in the past we used to say textbook good blood pressures are if you're anywhere in the 120s and anywhere in the 80s, that's good. Well, now the American Heart Association is saying no, that's not good, because they're diagnosing people with having prehypertension, an elevated blood pressure in the 120s and in the 80s. So more people today are being diagnosed with elevated blood pressure and hypertension because they have those higher numbers. So just note, and I've also included that same table for the most part, but you can see the new numbers that the American Heart Association has come out with. Normal blood pressure less than 120 over less than 80. Elevated blood pressure is the 120s, and the diastolic should still be less than 80 for elevated. Hypertension stage 1 is now in the 130s and in the 80s. Okay, so if a person has a blood pressure of 134 over 82, they would be diagnosed as hypertension stage 1. So that is a big change. So if you look back at this slide that's in your textbook, they're diagnosing stage 1 hypertension as the 140s. That is not the case anymore. So I know the textbook will probably be updated here with this new edition that's going to come out, but I want you to be aware that hypertension now is in the 130s and the 80s. Hypertension stage 2 is 140 over 90 or higher. Okay, so please put that in your head so we know those new updated numbers, okay? So also for hypertension, many people are on medical management. So they have to take drugs, for the most part to get that blood pressure under control. And the common drugs that they take are beta blockers, calcium channel blockers, and ACE inhibitors. So the more common ones that we might see issues with as a personal trainer are the beta blockers because they prevent a heart rate response to exercise. So meaning they will lower our clients' heart rate. So in that case, if we know a person is on a beta blocker, and we're going to ask those questions up front, right? We're going to ask what kind of medications are you taking so we can understand how that impacts their response to exercise. So if that's the case, we're going to use the RPE scale instead of using heart rate as an indicator of intensity. Calcium channel blockers also we know can cause blood pooling. So thus, these people might need an extended cool down right after they get their heart rate up when they do aerobic exercise. But they need clearance for the most part from a physician. We need to know as a personal trainer that their hypertension is medically controlled in order for them to participate. So we want to make sure that they've got that blood pressure under control through medications before we can actually work with them. Other things in this chapter that it talks about are cardiovascular disease. And there are 3 disorders that are linked to atherosclerosis. So atherosclerosis is when we have that plaque buildup on the walls of our vessel, and they cause it to be what we call occluded. So this plaque buildup causes that normal vessel, which looks like this picture in the top, to become occluded, and now you can see that the diameter of that vessel has become even smaller from that occlusion, allowing less blood flow to get to the area that it needs to get to. So that can happen with an MI, a myocardial infarction, which is a heart attack. It can happen with a CVA, cerebral vascular accident, which is a stroke. So you might have a vessel in your brain become occluded versus in your heart. Okay, so a blood vessel in your brain, when that becomes occluded, people can suffer a stroke. And then PVD, peripheral vascular disease, is an occlusion of a vessel that affects the periphery. So in your arms and your legs, for example, we can have occluded arteries, which leads to PVD, peripheral vascular disease, which can cause pain in their legs especially. So these 3 are all related to that atherosclerosis, and they're a result of that occlusion that occurs in our vessels, whether it be in the brain, which is stroke, a CVA, whether it's in your heart, which is an MI, myocardial infarction, or whether it's in the periphery, arms and legs, for example, which is PVD. So here are your general recommendations when you look at any of those cardiovascular diseases. Remember, I said knowing the differences for each individual disorder or special population is going to be too hard to memorize. But in general, when we look at all of these cardiovascular diseases, they kind of overlap each other as far as what are some generalized recommendations. So when we look at aerobic exercise, generalized recommendations are 3 days a week for MI, PVD, cardiovascular disease. So doing anywhere from 5 to 40 minutes per bout. Look at 5 minutes. So starting as low as 5 minutes. So those clients who are post-MI, maybe 5 minutes is all they can handle. And then we gradually work up from there. Start with low intensity, 30 to 40% of maybe their heart rate reserve even, and an RPE of only an 8 or a 9. Now that's going to be on the 6 to 20 scale. So you're looking at, on the 1 to 10 scale, maybe an RPE of a 3 or a 4. Resistance training, 2 days a week, only 1 to 2 sets of each exercise, higher repetitions, 15 to 20, but still a longer rest period. They need longer rest periods, okay? Gradual progressions, body weight exercises are probably the best thing that we can do for them. As far as flexibility programming, there's not really anything specified, but if they are able, we can work on some flexibility. But for this group, really, aerobic is so important because we want to make those arteries healthy, right? So work on strengthening the heart and lowering that atherosclerosis. So other precautions to think about is these are higher risk groups, so it's always a good thing to get physician clearance. So make sure they're, talking to their doctor, saying, hey, I'd like to do this with a personal trainer. What do you think? And get their okay. The Valsalva maneuver is not recommended. So what that is we hold our breath, right? A lot of times people, when they do a resistance training exercise, they hold their breath. And we know that when you do that, that increases intrathoracic pressure. And people who already have high blood pressure, it can worsen the effects of high blood pressure. So for this group especially, Valsalva is not recommended. No holding their breath. So we want to make sure we're cueing them regularly on how to, when to exhale, when to inhale during these exercises. RPE may be advised instead of heart rate. Like I said earlier, if they're on a beta blocker especially, that's going to slow their heart rate down, so that affects their response to exercise. So instead, use the RPE. And then monitor them regularly. So while they're exercising, you want to make sure that you're paying attention to them. Do they have any difficulty breathing other than the norm? Do they have any pain in their chest or their limbs or their neck? Those are all signs that maybe they're having a heart attack. Something is going on. So we want to make sure that we're closely monitoring those populations when they're exercising with us. So other precautions when we're looking at post-MI, myocardial infarction, so heart attack, and hypertensive clients. They have similar health and fitness goals. The main goals of these two groups is to, one, control their blood pressure, because people who have had a heart attack, they most likely will have high blood pressure, okay? Also, they want to improve their aerobic capacity. That's key. And then they also want to improve their muscular endurance. So health and fitness goals are really similar for these two special populations. Versus when you're looking at PVD, peripheral vascular disease, and stroke, these folks are going to maybe experience loss of certain motor functions. So we want to work on ADLs, activities of daily living, so they can, do things around the house that they used to be able to do without any issue. We want to focus on those activities of daily living and how can we program to help them better perform those activities. But again, as far as goal setting, you can see there is an overlap with a lot of these, special populations. So all four that are listed in this chapter, you can see there is somewhat of an overlap when we look at programming for those special populations. So that is it for chapter 20.